Thank you. Before I introduce Dr. Quresh, really the distinguished speaker, I thought I might as well let everybody know what our Rotary E-Club stands for. Rotary E-Club, one of Rotary E-Club signatures project is the gift of sight. We always talk about trying to do something good, but we always take a long time before we get things going. All good things take planning, take a long time to get going. And it was only about 2016 that we really got the ball going. And we did the gift of sight in Nepal. We did 1,032 cataract eye operation. Then we went to Indonesia, Bandung, Indonesia, and we did 700 eyes at that point of time. However, COVID came around and it hit us and everything has to stop because we are not able to go out and do all our wonderful work in society, in the community. Hopefully, early next year, 2021, we will be on the ball again. And the plan is to do up to 1,100 cataract eyes in Bandung, Indonesia. We're going to do 400 eyes in Bangladesh and another 300 eyes in Sarawak, Malaysia. So a lot of things are happening and we are all excited. Myself, I have a problem. My problem is that I'm going blind. But then thanks to doctors like Dr. Quresh Maskati, I'm saved because I'm going to be able to see forever and with new visions. So ladies and gentlemen, I'd like to introduce you to my savior, who is going to help us and share with us what wonderful things that's happening in the world of blindness prevention. Ladies and gentlemen, this gentleman, past president of the Rotary Club of Bombay North in 1995-1996, is a real achiever because every time when he's young, he's always the first. He got gold medal in this place, recognition as the youngest president, youngest this, youngest that, and everything. So today, he's also young, and I'm also young, because I also will have a young eyesight after he share with us simplifying your eye care, because he will share with us about the modern advances that's happening. And I like Dr. Quresh Maskati's delivery because it's very nice, it's very simple. He doesn't give you a big bombastic word, which I cannot understand. And the way he delivers it is very humorous. So I'm sure you will be able to testify to that. So ladies and gentlemen, let us welcome our guest speaker, the past president, Dr. Quresh Maskati.
Thank you. Thank you. Thank you so much.
Clap, 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 clap.
So thank you very much, Dr. Chi and President Eddie Ho and all the members of the E-Club 3310 from Singapore. It's my pleasure to be there. I wish I could have been there physically because I've been and lectured in your wonderful country at least 5 or 6 times before. I have lovely memories of both the Singapore General Hospital and the SNEC, Singapore National Eye Center, where I've spoken, and I have many good friends amongst the eye surgeons there. As I was telling Chi, that one of your former ministers, Vivian Balkrishnan, was a former faculty at the SNEC. So my aim, my mission is to simplify the recent advances in eye care. You must understand that eye surgeons love to complicate things because that's how we make our money. You see, EYE, eye is a very small word, so people don't give too much importance to this. So we call ourselves not eye doctors, which is simple, but we call ourselves ophthalmologists, which is so difficult to pronounce and spell that most people make an error there. So, but we feel good because we got such a long name to it. And even all our diseases, actually they're small diseases because the eye is a small thing, but we make them sound so terrifying that you pay good money to get treated. So I will request you to put your cell phones off if possible or on silent mode, as most Rotarians do. And we'll go on with simplifying recent advances. Before that, we need to see What exactly are we talking about? What is an eyeball? What does an eye look like? So the eye is the front portion of the eye is called the cornea. The cornea is like the clear glass in front of my Rolex watch. Not that I'm trying to boast about my Rolex watch, but I do have one. And the cornea is the clear glass which is in front of the watch, except that my Rolex watch, the glass is flat, while our cornea is dome shaped, as you can see in the picture. Behind the cornea, there is an empty space filled with fluid, water, which is called aqueous. And behind that is the, in Indians, dark brown portion of the eye called the iris. It could be blue, it could be green in white Americans, Europeans, but in India, Singapore, mostly it is different shades of brown. In the brown portion of the iris, there is a small hole where nothing is there. That's called the pupil. So light goes in from the cornea and goes through the pupil to the lens of the eye. Now the yellowish thing that you can see is the lens of the eye. Those who are my age and above will remember once upon a time we had film cameras. So we had a lens in the film camera roughly where this lens is. And that bent the rays of light to focus on the film, which was always at the back of the eye. So the film which is at the back of the eye is called the retina. So the cornea and the lens together focus the light to the back of the eye, where there is the retina, which converts the pictures into electrical impulses, which go through the optic nerve that you can see to the extreme left, the optic nerve, which is the nerve of the eye, as electrical impulses, and they are received by the brain right at the back of the head. And there the brain interprets what is there, what is shown, and that's how you see an image. So this is how we see the jelly of the eye between the lens and the retina at the back, the blue area that you're seeing, that's called the vitreous jelly or the vitreous humor. And surrounding the eye is the conjunctiva. It's a thin membrane which covers the white portion of our eye. So the white portion is called the sclera and the thin membrane is called conjunctiva. When our eye becomes red, or when we get conjunctivitis or red eye, then you can see the conjunctiva inflamed or red. Otherwise, it's transparent. Let's move on to the disease which many people have. Our president has just had surgery for this, which is called the cataract. So what is cataract? You see, I told you about the pupil of the eye. Behind the pupil is the lens. The lens can become opaque. It is normally clear, but the proteins in the lens can become opaque. And when they become opaque, it becomes little whitish. And if it becomes very opaque, like in the lower right, it becomes pearly white. So that's called a cataract. A cataract is any opacification of the lens of the eye. So in the previous days, when a patient had a cataract and the vision went down, then the whole cataract was removed. We must first understand what is the treatment of cataract. There is no medical treatment, no drops, ointments. Sometimes people try to fool the patient by telling them you put so-and-so drop or so-and-so ointment and it will reduce the speed at which your cataract is progressing. That's rubbish. And then when doctors don't speak rubbish, then there are neighbors and friends and relatives who tell them you do this exercise or yoga or acupressure or even urine therapy. In India, a lot of people try this, drinking their own urine or putting urine drops in the eye. All rubbish. So the only treatment is surgical. The modern treatment is by a process called phacoemulsification. Now, again, I told you how we love to confuse you with big words. Phaco in Greek means lens, and emulsify means to liquefy. We have a liquidizer in the kitchen in which you put carrots and you make carrot juice. So you squeeze the carrot and you get carrot juice. So phacoemulsification means the lens of the eye is liquefied and it is sucked out. So in 99% of cases, no laser is used, but almost 50% of eye doctors will tell you that we will do it by laser treatment. So when you suck out the contents of the bag, now imagine the cataract to be in a shopping bag, and you remove the contents and leave the bag in place. Inside that bag, you put an artificial plastic lens called IOL or intraocular implant. So it replaces the human lens, and we take measurements to find out what power of lens we should put in so that you use the minimum spectacles. And you put it in the same place from where the human lens was removed. So the eye looks normal after surgery. The picture on the top shows you a normal looking eye with the black pupil in the center. Patient has had surgery just a day ago, and you can hardly tell that patient has had surgery. Just like Eddie has had surgery, and with that plastic on his eye, you can hardly tell that Eddie has had any surgery. So the eye looks fairly normal after the surgery. So when in that case, when should we be doing surgery? When is a cataract ready for surgery? So in the good old days, if you couldn't see the fingers in front of your eyes, then it was ready because we wanted it to be very, very mature, because we'd remove the whole cataract with the shopping bag. And sometimes when we were removing it and that bag broke, the contents of the lens would be strewn into the eye and cause complications. So we would tell the patient, don't come back, say you can still see your fingers in front of your eyes. Don't come now, come next year. Now, it is when the patient is prevented from doing his or her daily routine. So if the president felt that he wanted to play golf and his golf game was suffering, that's his daily routine. He needs the surgery. So the same density of cataract may require early surgery in a busy executive and may be deferred in the middle picture, the 90-year-old lady who doesn't watch TV or read. She just wants to see where her food is on the plate so she can eat by herself and go to the toilet. So for her, I might say we'll do it after 5 years because she's happy with her vision. But for the executive with a golf game coming up with big wagers on who's going to win, for him, it's important that he gets his cataract out of the way. Or if he signs $1 million checks every day and the signature differs and the bank says you're a defaulter, he needs the cataract surgery. So different people with the same density of cataract, some may require early surgery, some may require later. But important thing is the decision should be of the patient. Don't let the doctor hurry you up, because the doctor has a commercial interest in doing the surgery, especially if he's in private practice like me. So I tell the patient, you should get it operated by today evening, by tomorrow it may burst. That is rubbish. Cataract is never going to burst, even if you wait for a year, 2 years. So whenever you feel that you're not happy with your vision, only then you give the go ahead to the doctor, because he's always ready to, let's do it immediately after this lecture, he'll say. So what anesthesia is given and how long does it take? That's the questions people ask. So it can be done under topical or eye drop anesthesia, where no patch is needed to be put after the surgery. I usually prefer to give a local injection anesthesia, just a small injection outside the eye, in which case I put a patch on the eye for a few hours after the surgery. Doesn't matter, it depends on what your doctor likes to do. If you're a cooperative patient, he might decide to do it topical anesthesia, or he might give you a small injection. Usually, if we do it in small children, sometimes you get cataracts in small children, we may give full general anesthesia. Again, I love this question of patients, doctor, how long will it take? It's as if they're going to go and meet a girlfriend immediately after and can't wait for an hour. How does it make a difference to you how long it takes? It lasts, usually the actual surgery lasts for 15 minutes to 45 minutes because we use sophisticated machines. We have to prime the machine, recheck the machine, put all sterile drapes on you, check everything is all right. So all that sometimes takes 15-20 minutes. The surgery may take 15-20 minutes. Then we make sure you're all right. 3-4 minutes, we may keep you in. So all along, you may be in the operation theater for 45 minutes. Somebody may be in the operation theater for half an hour. They'll go out saying, my surgeon, marvelous. He got me out in half an hour. Your surgeon, useless. He took 45 minutes. Rubbish. It doesn't matter. And you can go home immediately or in a couple of hours. Usually we send the patient home when the patient is feeling fine. Depends on what kind of anesthesia and how groggy the patient is. And there are very few restrictions after surgery. So dark glasses are usually not required or recommended. We allow you to go back to the computer and to Rotary meetings almost immediately after the surgery. Now, what was the method of surgery earlier? If you again remember that picture of that yellow lens in the middle of the eye, in the good old days, thousands of years ago, they used a blunt instrument and pushed on the front of the eye. So the lens just fell down into the jelly of the eye. That was called couching. And then later on in the last 50, 60 years, we've been using a big incision in the white of the eye with a lot of stitches over there. It's a large incision because you have to remove the lens out. So it took a lot of space. So a large incision. So we have to make sure the patient didn't move his head, And we had to tell him for 5 days, don't move, don't strain, don't cough, because the stitches would break. And we were afraid of stitches infection. So we put lots of antibiotics, but no more. And now we have the laser surgery, which I told you is only about 4 to 5% of surgeries, even in Singapore, is done by what is called femto laser assisted surgery. Femto is actually a laser which softens up the lens. So here you're seeing a patient being put under the laser. The laser makes marks and cuts in the lens of the eye, but they are only partial thickness. So it only softens the lens up a little bit in one room. Then the patient is shifted into another room where the regular surgery is done. So the femto laser does not do the surgery. It only assists. It does the first part of the surgery. Almost 90% of us do surgery by what is called phacoemulsification. As I told you, phaco is lens and emulsifies to liquefy. So we put a small incision, as you can see in the center, and we put a pen-like instrument, like a ball pen, which goes into the eye to where the lens of the eye is, as you can see in the top left, the lens of the eye. And then it eats up the lens of the eye. It emulsifies it. You can see a hole in the center in the lower central picture. There is a fluid which is coming down from a bottle which is on a height, and the fluid is churning up the lens material. And in the center, there is a tip which is vibrating at about 40,000 times per second. It emits ultrasonic energy, so that lens becomes broken into tiny bits which are sucked out through the hole in the center. So that bag, the shopping bag, becomes clean. And you can see right on the top right, the phaco tip, which is eating up the lens material. It's so also in the middle right. And then a new lens is being put in, folded in its place through like an injection needle. And as it goes into the eye, it unfolds into that shopping bag and sits where your lens was. And that's the surgery which is over. On the left side of the screen is the actual machine. And we look through a microscope when we are doing it. So we look like people from the space age. So most cataract surgeries, as I told you, are done by phacoemulsification, and a folded lens is put inside. Now there are two types of lens implants. One is what is called unifocal. In unifocal, we correct you for a particular distance. Usually we correct you for distance, so that you can see fairly well without any glasses for distance, but you need reading glasses. Or we may decide to put what is called a multifocal lens. Just like you have multifocals in spectacles, you have progressive spectacles, you have also a multifocal lens, lower left side of the screen, which has got rings in it, and it corrects you for distance and for reading. And if you have a cylindrical number in your eye, or what is called astigmatism, we might correct that at the same time, in which case we put a toric lens inside. So first cousins of the multifocal from the mother's side and father's side are trifocals, and extended depth of focus or EDOF IOLs, they're all cousins of the multifocal lens. So you either have a unifocal or a multifocal lens. Now some patients are unhappy. Doc, you charge me so many Sing dollars and I still need glasses after surgery. Why? What went wrong? Tell me, doctor, something has gone wrong. You're not telling me. No, nothing has gone wrong. The machine used to calculate the ideal lens power, which is called an A-scan machine, may not always predict how your eye will heal. You might have a pre-existing cylindrical or astigmatic number, and we didn't use a toric IOL because it's high cost. Even the small incision which I made for the phaco surgery may induce a small number. And of course, if you have a unifocal IOL inserted, you will need glasses for some other distance, either for near or for distance. So that's why some of us need but small number of glasses, not very thick glasses. Then sometimes after successful cataract surgery, patient says, I was seeing very well, doc, for 6 months. Now I'm seeing a little blurry. Why is that? Something's gone wrong. See, the patients are very keen to know that something's gone wrong. Can we sue this doc successfully? So no, nothing really has gone wrong. But I told you about that shopping bag. The shopping bag in which the lens had been put and the bag was very clean. The bag can become a little dirty, like you see in the left, lower left. The bag gets opacified, that white spots in the bag. So the vision becomes very blurry. So what do? I put you in front of an instrument which is called a YAG laser, which is in my office itself. And I blast a central hole in that bag. Don't blast the whole bag, otherwise the lens will fall down. but I blast a central hole. You can see that the bag is white, but in the center I've made a hole. So clear light can go in and you can see wonderfully well. It's a 5-minute painless procedure called YAG capsulotomy. Moving on from cataract to contact lenses, what are the recent advances in contact lens wear? Some of the youngsters who are there listening. Previously, we had only hard lenses or semi-soft lenses. Now you have soft lenses, and you have also have toric soft lenses where the cylindrical number can be corrected. And now, when we normally wear contact lenses during the day and remove them at night. Now, to correct myopia or minus numbers in children, because you can't do laser in children, we can do what is called orthokeratology, which is wearing of contact lenses only at night. So the mother puts the contact lens on at night. That contact lens presses on the cornea and reduces the need for glasses or contact lenses during the day. So the child can go to school without any glasses or contact lenses. So that's a new science which has come up called orthokeratology. And of course, there are specialty, for the adults above the age of 45 and who require reading glasses, you can have multifocal contact lenses itself, so you can see distance and near. And there are specialty contact lenses, funky contact lenses of different designs. You can have the Singapore flag on them for fashion purposes. And there are special lenses for the cornea. When the cornea is conical, then you have special scleral lenses or large lenses for keratoconus and for dry eye patients. So for these, you can see on the top right, the various funky lenses. You've seen them in horror films. So they just put on these lenses. The central area is clear. So the light goes through the pupil and patient can see. But they look ghastly, but people like them. So they wear it for fashion or for movies. You can get in the middle, you can see the bifocal or the multifocal contact lenses, which are very similar to multifocals in the spectacles and multifocal in your lens implants. And if the patient has got dry eye, we have very large lenses called scleral lenses. If you see the lower part, you can see the size comparison. I'm holding in 2 fingers the scleral lens, which is huge, and the normal lens, which is much smaller in size. So why is that? Because the scleral lens, we can fill in some fluid inside and you wear it so it wets the eye all the time. So even if the eye is dry or if the cornea is conical in the lower left side, it covers that area and the vision is very good. Next. Moving on to something which is very exciting since the last 20-25 years is the laser removal of eye numbers, which is called LASIK. For this, the patient has to be above 18 years and the number should have been stable for the past 1 year. You can remove up to -10 number in most cases. You can remove plus numbers, cylindrical numbers as well. On the right, lower right is the LASIK machine where the patient is lying down. It's also called flap and zap treatment because the cornea, again, you can see on the lower left, the cornea is split open like you're opening a Pepsi or a Coke tin. You split it open, but it's on a hinge. You don't remove the whole cap. So it's on a hinge. The hinge is kept in place and then laser light, you can see the blue light coming from above. It thins out the cornea by a definite amount, which the computer calculates. And then the flap is put back into place. So that's why it's called flap and zap. It takes only 10 minutes. There are no injections. There's no patch. And both eyes are done at the same sitting, unlike cataract surgery. You rest at home just for a day, eye drop perhaps for about 15 days, and you're okay. You can start seeing the computer the next day, and there is 0 numbers in all good cases, which is about 98-99% of cases go very well. So this is laser or LASIK treatment for number removal. The removal, we normally do it after the age of 18 and can be done up to any age. The newer advance in LASIK is called Femto Lasik or the smile procedure, where instead of making a LASIK flap, we make a small opening and we use only laser, not a machine. In LASIK, we make a machine to make the flap and then the laser is applied in LASIK. It takes about 20 millimeter size that the flap is made. In this smile procedure, only a 2 millimeter incision is made and therefore it's called bladeless. So some people who have this phobia of a blade touching their eye, we do this smile procedure. Of course, it costs much more. You get rehabilitated a little faster. There's less chances of dryness, but the conventional LASIK works equally well. When I did LASIK for my daughter, when she was about 24 years of age, I had both the machines with me, but I chose the regular LASIK. So there's nothing wrong in the LASIK. for commercial reasons, the doctor might try to push you into the more expensive smile technique. Let's go on to something which we are seeing increasingly amongst Rotarians, and that is dryness of the eye. We must remember that our eyes are 60% less tears at age 60 and above compared to at age 18. Not our crying tears when our spouse abuses us, which is common with all of us Rotarians, but those tears which we cry when the spouse abuses us, unfortunately, don't wet the eye. They're not good wetting tears. The quality of the tears is not good. According to the spouse, quality of everything of ours is not good, but we let that pass. Tuition, our use of the computers, especially because of COVID, now we're all stuck to our computers. Lots of medicines we take because of our stress. In Mumbai, about 50% of the population is taking antihypertensives for blood pressure or for diabetes or for depression. And all those medicines which we take, or for acidity, all because of stress, all those medicines produce dryness in the eye as a side effect. Also, people are living longer. Most people died at the age of 60 about 100 years ago. Now they're all living to be 100. So you are seeing more and more incidents of dry eye. Contact lens users are more. Contact lens itself can cause dry eye. So now we've got lots of new lubricating eye drops which are safe. And there are some drops like Restasis and Revamidpide, which are new medicines which actually increase our tear secretion. So they can actually restore tear production in mild to moderate cases. So there is good stuff happening in dry eye in the medicine part. Also in the diagnostics, we now have expensive gadgets for diagnosing which of your, our tears have got 3 layers: an outer oily layer, a middle sticky or mucin layer, and a middle watery layer, and an inner sticky or mucin layer. And we can diagnose with these equipment that you see like LipiView or Mybography. I won't go into details. This is just to impress you with my knowledge of technology and gadgets and to show you how expensive things can be in dry eye management. And then we've got the expensive treatment as well, which stimulates your glands of your eye to secrete better quality tears. What is called intense pulse light treatment, or IPL treatment, or LipiFlow treatment. So these are all high-tech gadgets, both for diagnosis and as well as for treatment of dry eye. Let's move on to something which is very low-tech, which is squints. Squint is low-tech, but squints have a lot of misconceptions. Many people believe that squint is a gift from God. If your eyes are not looking straight, one eye is looking straight, one eye is looking either inwards or outwards, that's a squint. But all squints can be corrected. Age is no bar. Ideal age should be before the age of 5 years. 2 reasons. One is you can improve vision, because when there is a squint, that eye usually becomes lazy. If 2 eyes are not being used at the same time, one goes a little lazy. So if you do the surgery before the age of 5 years and correct the squint, then you prevent that eye from becoming lazy. Also, kids with squint get an inferiority complex. When they're in class and the teacher asks a question, they don't answer because they're afraid that everyone will look at them and realize they're different. They don't make friends easily and things like that. So the earlier you get the squint corrected, it is good. And squint does not recur after properly done surgery. Many places, I do a lot of squint surgical camps in the interiors of India. And many of the villagers feel that the squint will come back, what's the use, and things like that. It doesn't happen. What are the recent advances in squint? We use what is called adjustable sutures in the cities, of course, not in my camps. So we take stitches and we call the patient the next day, and we can adjust the stitches so that the squint is even more perfectly corrected. And when the squint is because of paralysis of a muscle, we can use Botox to help these patients as well. Moving on to corneal diseases, which is my specialty, as Chu told you, that cornea is my specialty. So we have got, just like you have CT scans of the brain, we have CT scans of the eye itself, of the cornea itself. It's called OCT, or ocular CT scan. And the cornea is made up of multiple layers. And you can see that all the layers are pointed out: EPs, epithelium, then basement layer, then stroma. I won't go into details. I'm just again trying to show off my knowledge. But you can see that there are individual layers of the cornea. So we know where the disease lies, in which layer of the cornea. In the old days, we used to change the whole cornea if the cornea was bad. Now, for example, you can see this young girl with a cornea which is good in the right eye and very opaque in the left eye. So imagine my Rolex watch again with the glass opaque, so you can't see the time. So in the good old days, and in the middle picture, you can see the cornea has got an opacity in the lower half, upper half is all right. So in the good old days, we would change the entire thickness of the cornea. You saw how thick this cornea is, this thick cornea, we would change the whole thickness. But now, so this is a patient where the whole cornea was changed 36 years after the corneal graft was done. The cornea is now crystal clear, like the glass in front of my Rolex. Not that I'm trying to promote Rolex, I have no shares in the company, but just as an example. So it had excellent results. But nowadays, we can use one cornea for two patients. So instead of a full thickness corneal transplant, as you can see on the left, we can do what is called a lamellar transplant. So if the upper half is diseased, then we can change only the upper half. And if the lower part is diseased, we can change only the lower part, and we can split the cornea so that the upper half goes to one patient and the lower half can go to another patient. So one donated cornea can be used to restore sight to two blind patients. So that brings us to eye donation. Very noble cause. In Rotarians in all over the world promote this. So who can donate eyes? Anybody can donate eyes. Any age, any sex, any disease. Even if you have cancer, you can donate eyes after death. It has to be after death. Even those who have had cataract or glaucoma or retinal detachment surgery can donate their eyes, provided their cornea is clear. Relatives need to call any nearest eye bank within 4 to 6 hours. No paperwork is required. It takes only 30 to 45 minutes for the eye bank team to come and collect the cornea. And a small quantity of blood is also collected because it's tested for HIV and other things. And is there a need for eye donation? Yes. All over the world, there is a waiting list of millions of patients. In the US, they are net surplus, so they export corneas. Sri Lanka is surplus, so they export corneas. But in India, Africa, everywhere, there is a huge waiting list of patients. In India, some places, the waiting list is 1 year. A patient registers for a corneal transplant and gets a cornea after 1 year. So eye donations received all over the world is much less than the requirement. So the backlog keeps increasing. And you don't have to pledge your eyes before death. You don't have to tell, it's not necessary that you have told your near and dear ones. It helps if you've told them because they remember it. And when you're no more, they can, instead of burying you or cremating you, they have a heart and they call the eye bank first before they do that. And the eye bank comes quickly, removes the eyes, and then it can be used, your 2 eyes can be used to restore sight to 4 blind patients. Sometimes the artificial eye cornea has to be used in a patient who's got very bad chemical burns, very severe dryness of the eye with absent tear secretion, or the graft has failed, corneal graft has failed numerous times. Then we have to use a plastic cornea or an artificial cornea. I do 2 types. One is called the Pintucci keratoprosthesis and one is the Boston keratoprosthesis. These are very complex surgeries. Unlike a phacoemulsification or cataract, which takes just half an hour, this takes about 2-3 hours each, and it's usually done when both eyes are blind. I've done these cases in several cities in the world, like in Manila in Philippines and in Kuala Lumpur, close to you, where I've demonstrated these procedures. And there are just a handful of surgeons the world over which are doing these complex cases. But just, I thought I'd include the slide to show you that even complex cases with very severe eye injuries rendered hopeless earlier, they can be given sight. Moving on to a glaucoma, which is a silent thief of sight, and Chu is one of the people suffering from glaucoma. So all Rotary Club members above the age of 40 should get themselves checked by an eye doctor for glaucoma at least once a year, because it's a silent thief, as I said. Those with a family history of glaucoma, those with diabetes are at greater risk. What happens in glaucoma? We lose the peripheral field of vision. Means if you're looking straight ahead, you see the middle picture, the boy with the football. You can see the boy with the football right up to the end stage of glaucoma. But the periphery, if there are 5 kids on either side, you don't see them. It's all dark around. You can see the blackness around the boy. So the peripheral field of vision is lost till we are left with a very tubular field. As you see on the lower right slide, you can see that image of the building, but everything else is hidden because it's all black. So you're left as if you're looking through a tube in glaucoma. And then slowly the tubular vision also goes away and you're left with blindness, provided you've done nothing about it. But the moment you are discovered to have glaucoma, with modern medicines and with surgery, we can maintain the current vision. We can't improve the field of vision, but we can certainly maintain it for life, so you will lose no more vision. So the prevention is better than cure. An early step when the field of vision is good, then you can keep that field of vision healthy by going to the doctor. So a preventive checkup, just like for blood pressure, we say after the age of 40, at least get your blood pressure checked once a year. You should get your eye pressure also checked once a year. So what's new in glaucoma? There are better machines to measure pressure of the eye, and we have computerized visual field analyzers for early detection of the field loss. As you can see in the upper right, the gray area is where the patient has lost field and the rest of the field is preserved. And there are many other sensitive tests to detect early glaucoma, such as contrast sensitivity test and the OCT for the retina and HRT. These are all to see the nerve of the eye and how it's doing. And we have a lot of powerful eye drops to lower eye pressure. If one doesn't work, we can change to another one, or we can give a combination of 2 drops. And if drops don't work, then we have more effective surgeries to permanently reduce the pressure, such as glaucoma regular surgery or even glaucoma valve surgery, where we put a valve into the eye so that the pressure, whenever it rises, the fluid inside the eye is drained out. So the glaucoma is where the pressure in the eye is high because the fluid is under higher pressure. Moving on to diabetes eye disease. The longer the duration of diabetes, the more the chances of retinal affection. The worse the control of the diabetes, of course, the more the chances of retinal affection. Again, all diabetics therefore should visit an eye doctor for examination of the retina at least once a year. Those with retinal changes may be called oftener by the eye surgeon. Besides retinal problems, diabetes can cause earlier cataract, more chances of glaucoma and dryness of the eye. So if you have diabetes, it's much better to go to the eye doctors at least once a year. Now the picture on the top, the red colored picture, that's the retina. The eye doctor may take a picture of your retina to compare when you come a year later. The yellow thing is the nerve of the eye, and there are blood vessels which are coming out from the nerve and going all around the retina. And the central black dot is the macula, or the most sensitive layer of the eye. 80% of our vision is from that black dot area, the sensitive macular area. What happens in diabetes? You get cholesterol deposits and you get blood clots all over the retina. You saw the picture here where the retina is clean, nice, red colored with no spots on it. And now you see here that the blood vessels are engorged, they are of different sizes, they are leaking. So the yellow stuff which is coming out is cholesterol deposits, and the red stuff which is coming out is blood, which is leaking there. So the eye gets filled with fluid, with blood, with cholesterol deposits, and the vision goes down. And if we find this very early in life, like you see on the left side, then we can do laser treatment to the retina, and we put in some laser spots to seal all the leaking blood vessels. And we can save the eye from further leakages. That's the laser on the right, upper right machine which is being used. You can do it in the patient in the sitting position of his procedure. And there are newer diagnostic methods. One of them is like you have coronary angiography to take pictures of the blood vessels, the heart. We are not far behind. We have fluorescein angiography. We take pictures of the blood vessels of the retina, and we can see the leaking areas. You can see those white spots. Those are all the leaking areas. And I told you about OCT of the cornea. We have OCT of the retina. So like a CT scan of the retina, you see this green picture, and you can see the black areas are the waterlogging of the retina is very boggy with waterlogging. So we can take pictures and we know how much of fluid is inside and what is to be done. So there are new diagnostic tests for diabetic eye disease. If it's left untreated, the bleeding may occur in the jelly in front of the retina, which is called vitreous hemorrhage, or vitreous is the jelly. Hemorrhage is to bleed. I told you we love using fancy words. And that jelly becomes contracted rope-like and may pull on the retina, causing a detachment of the retina. So in that case, we have to do a procedure called vitrectomy, which is a machine which goes in and eats up the jelly of the eye and replaces it with an artificial jelly. So that's called vitrectomy, which is done in late stages. If you are careful and get your diabetes examined once a year, you may never require this. Then as we live longer, there is something called age-related macular degeneration. Previously, we called it senile macular degeneration, but we old people don't like to be called senile. So we call it age-related macular degeneration. There are two types, what is called dry and one is called wet. In the dry type, there is just some cholesterol deposits in the center that you can see in the middle picture. And those deposits come very slowly and the vision goes down a little, not too much. You can still read with good, a little more powerful glasses. The good thing is that you never progress to blindness if you got dry type. The bad thing is there is no specific treatment. So we give what is called antioxidant pills, which are good for the pharma companies. The other type of macular degeneration is called wet type, where there is fluid filled, as you saw in the OCT of diabetes. Similarly, you can get fluid in the macular area. And this can be treated with either lasers or injections in the jelly of the eye, which need to be repeated and are expensive. You can go blind also in this, but you can get perfectly normal also with these injections. So it's a double-edged thing. So these are intravitreal injections. They are called anti-VEGFs. Just to again show off my knowledge, VEGFs is anti-vascular endothelial growth factors. So the trade names are Lucentis, Eylea, Avastin. These are some of the injections which we give, usually given in a course of 3 injections at monthly intervals at just eye drops anesthesia. And we can review the improvement with the OCT. So you can see on the top in the green one, how boggy it was with the fluid before the injection, and after injection, it looks nice and flat. We move on from there to oculoplasty. So we can do, if you have got crow's feet, we can give Botox injection around for the wrinkles around the eye. If the lids are very baggy looking, then we can do a blepharoplasty, where we do a surgery to the cosmetic surgery to improve the cosmetic appearance. These we do with very radio frequency knives, which don't cause much bleeding. So this is cosmetic treatment has improved, and a lot of Botox injections we give to make you look young again and to fill our pockets, because Botox is nice and expensive. But with all the modern changes, amongst the last slides, I'll show you that there are no recent advances in the treatment of floaters and cobwebs. Many times we see some floating particles in our eye, and we go to the doctor and he says, your retina is absolutely fine now, don't disturb me. You can't do anything for the floaters. So I tell patients that just like when a spouse of yours is standing in front of you and you're lost in thought, and you ask your spouse, when did you come and stand here? And she says, I've been shouting at you since 30 minutes and you didn't hear her or see her. So if you could, miss out on a 5'5" spouse, these tiny floaters and cobwebs you can learn to ignore. We make it a fine art to ignore spouses. You need to ignore these floaters and cobwebs once the eye surgeon has told you that there's nothing to worry about. And the optic atrophy, if the nerve of the eye dies, either due to glaucoma or injury or some other reason, and it becomes chalky white that you see there, then it's like a person who's brain dead. There is no treatment for this anywhere in the world. There is also a condition called night blindness, which affects a very small percentage of population, usually those who intermarry amongst cousins. And this is called retinitis pigmentosa or night blindness. And unfortunately, there is no treatment in the world for this. Also, a very simple condition called red eye or conjunctivitis. Usually these are viral, just like you don't have a treatment for cold, common cold, you can do what you like, but in 5 to 7 days, it'll take for the cold to go away. Similarly, with conjunctivitis, no matter what lovely eye drops you put in, it'll still take a few days for the conjunctivitis to improve. So we don't have any magic drugs for these simple things. To summarize, ophthalmology has made huge advances in recent years with better diagnostic gadgets, excellent operating microscopes and machines such as lasers and phaco. We have very fine suture materials, stitching materials, better eye banking with improved results in corneal transplant. There are newer medicines for dry eye, glaucoma and retinal degeneration, and safer cosmetic procedures. I'll be happy to answer questions. I thank you for your attention and I apologize if I've hurt anybody. I hope I've not given you too much information overload. Thank you so much, E-Club 3310, for inviting me.
Thank you. Any question, everybody?
Doctor.
I have a question.
Yes.
So, Dr. Maskati, this afternoon I was at the pool, and when I look at the sky, I don't see, it's not floaters. I see small packet of like round shape.
Yes.
Like, Do I need to
Yeah.
see an eye doctor now?
No, no, not at all. Not at all. See, you must see an eye doctor only if you have floaters which are continuously increasing in size. That means that if, or in numbers, for example, you see 5 floaters now and 15 minutes later you see 1,000 and 15 minutes later you see 20,000. So that's what is called an increase in floaters. But if you see 2 floaters today and 4 tomorrow, you don't have to see an eye doctor. Then if you have flashes of light which are persistent, they don't go away. You just flash, 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 flash all the time for 15 minutes at a stretch. Then you need to see an eye doctor because the retina may be showing an early hole or a tear. But if you see an occasional flash of light or some black spots, you have to ignore it completely. Don't see an eye doctor. Thanks,
Yeah,
Vicky.
Dr. Maskati, I did not see black spot. It's not black spot. It's white and like a hole, many hole or many bubbles.
And it went away, right?
It did not go away.
Are you still seeing it?
No, I don't see. I can only see at the against the sky. When I look at the sky, I saw.
So that is little changes in the jelly of the eye, which is perfectly normal, and you need to ignore this.
Thank you.
Oh, you save some money. You just got a free consultation.
Yeah.
This, Vicky.
That's worth $500.
Yeah.
Sunshine, sunshine.
Sunshine, yeah.
Any further
Maskati,
question?
can I ask you one question?
Please
When
go
you
ahead.
use the IOL, does it change
Yes.
the color of my eyes?
Not really, but sometimes if the light shines at a particular angle, it may give you a little reflection from the IOL, but it doesn't change the color of the eyes because that's the brown portion of your iris. That's there. We go behind that, so there's no change in color at all. It's transparent.
Hmm. And you're talking about a singular rather than multifocal, right? Singular.
Yes, you can do unifocal or multifocal. You have to discuss this with your eye doctor whether you want to not wear glasses at all or you don't mind wearing reading glasses. So then, because the cost is almost double or more for the multifocal.
I see.
I've got.
So would you recommend unifocal for most people?
Yes,
Because
most
I
people
find that
we would recommend
sometimes,
unifocal.
let me ask a question, because sometimes people say that, after using, having a cataract operation, initially it looks okay. And then after a while, I have to put on spectacles. So
Yes.
why is the transformation? Then in that case,
Yeah,
you might
because-
as well save money.
Yeah. That's why most of the time we put in unifocal, so they don't mind wearing a little glasses. Sometimes the wound healing may go on for about a year or so there may be a little change in the numbers. So don't make very expensive glasses immediately after the surgery. Wait for a couple of months. It usually settles down, and then you can make permanent glasses.
So it does change the power, in other words.
Little, very little, maybe half a number or so, not too much.
When you say
If
half
the
a
number
what do
changes
you mean?
quite a bit, it could be because of opacification of the capsule, the shopping bag, in which case you might require a little laser there. Yeah.
Okay.
Great.
Any other questions?
question? Yeah.
I have one question.
Dr. Maskati,
Yes.
sorry.
Sorry,
Yes.
go ahead.
This is James here. Are there methods that are proven, like for example, if you want to improve your eyesight, right? Like for
Yes.
example, the Bates method. Are these real?
No, they're all good money making for the guys who write books on better sight without glasses like W. Bates. So they don't really help. See, what happens is that when you do a palming exercise and you push your eye, the fluid in the eye goes out, so your eye flattens a little for some time, maybe a couple of hours. So your number seems as if it's gone down. But tomorrow, the next day you see the number is the same. So it doesn't really help. Neither does walking
Okay,
on
thank
green
you.
grass or walking barefoot in the park. None of those help.
Atika,
Okay,
you had a
thank you.
question?
Yeah, I had. What you just now you mentioned there was LASIK and then there was Flexi Smile, right? For LASIK operations, right? What are the risks attached to undergoing such operations?
Right. Now, I've been doing LASIK since about 22 years now, and I've done it for my daughter. So I guess the risks are not so great. About 2 to 3% people will have what is called undercorrection and overcorrection. That means if I'm aiming to correct -5 in both eyes, you could end up with a -0.5 or a +0.5 after the procedure instead of 0. which is not such a bad thing. -half or +half, you don't need to wear glasses. But if the number left behind is say 1 or more, then we do what is called an enhancement. That means we do a touch-up job at no extra cost to the patient within a year of doing the LASIK, and we can get rid of that number. But that's in less than about 1 to 2% of patients. In about 5% of patients, you can get a little dryness after the LASIK, but that might last for 2 to 3 months where you need to put lubricating drops, but then it all improves. No one gets permanently dry eye with the LASIK. And there's almost no chance of blindness.
Okay, that's cool.
Dr. Edmund here.
Yes. Yes, Edmund.
5-6 years ago, I had the eye surgery. My
Yes.
the eye, the wall of the behind the one of the thing fall. So I almost got blind, but the doctor managed to found the thing and he put back. Now
Yeah.
my
Retina.
eye is the retina. So
Yeah.
I had some problem right now also, like seeing in front. So sometimes it's very dark. So what
Yeah.
should I do now? Go for eye check again?
No, you can just go for a routine eye checkup once a year. After a retinal surgery, you should go for once a year checkup. But
Yes.
if you're seeing fairly well, that means your doctor has done a good job. Retinal detachment surgery is a difficult surgery, and you don't always get 100% results like in cataract. So we need to be thankful to the Almighty that we got back fairly good and useful vision. You see, the retina now has been detached and now attached. So sometimes you will get these the dark areas depending on where the light shines. If it shines on the area where laser has been applied to your retina, then you'll get a black picture there. So just ignore that.
Okay. Thank you very much, Doc.
Thanks, Eddie. Yeah.
Thank you.